To Dr. Peppercorn, who is in Gaza, to answer the question about a famine, risk of famine. Dr. Peppercorn? I'm sure that the connection is not stable. Do we have Dr. Peppercorn, or we come back to Dr. Peppercorn in a second? Well, let's maybe move on to next question. But Nina, we will try to call Dr. Peppercorn as soon as the connection gets better. So let's go to Carmen Pound from Political. Carmen. Carmen, can you please unmute yourself?
Yes. Can you hear me now, Tarek?
Yes.
Thank you so much. So yesterday at the World Health Summit, Dr. Michelle Yeo talked about the issue of testing in the DRC for Mpox particularly, and he mentioned something that many gene experts machine were left in the DRC after the response to the last Ebola outbreak, but they've been not functioning because of the lack of electricity. So I wanted to just get a bit more details on that. So are there sort of like testing, machines in the country, but the sort of like the lack of infrastructure is impeding their use? Or can you give us more details about what he was talking about yesterday? Thank you.
Dr. Yao.
Thank you very much, Carmen. We were in fact highlighting the challenging environment where the government is trying to respond to the Mpox crisis, and referring to the fact that it's a system that is overstretched. So electricity could be one of the issues mainly for infection prevention and control, but we have also in some places water supply issues. So it is not a misuse of what was left, but sometimes overuse, and then it requires additional support. And this is what all the partners with WHO are trying to do. To make sure that in places where we are having a lot of Mpox cases, we can quickly confirm, and that we can also implement our comprehensive range of intervention that is required, including active case search, confirmation, and then triggering vaccination, as well as also infection prevention and control, like making sure that in a given family where we have cases, we can at least supply some soap and make sure that they are also aware about the disease to prevent it. So it's a challenge related to the health system. And in these areas, overstretched by many types of crises. We have cholera, we have measles, already mentioned by the DG. So all these make the system overstretched, overused, and the time we have a major crisis, it's require additional support from different partners to make it happen. And it's what we are facilitating for us to be around the government to ensure that we can effectively respond to the crisis. We supply cartridges, more than 4,000 only this week, and we will continue to do so.
Thank you so much, Dr. Yao. Dr. Van Kerkhove?
Yeah, I just wanted to touch on the theme because what Michelle was talking about yesterday at the MPOC session of the World Health Summit is really around the sustainability of the work that we do in support of member states after all of these outbreaks. There's a lot of capacities that exist in countries. After each outbreak, there is more that is learned, and I'm going to ask Janet may want to come in and talk particularly around some of the work that happens related to medical care, IPC, in some of the healthcare facilities in these countries. But one of the things we talk about almost daily with all of our partners, and it does matter in terms of the investment round that we're talking about, is the sustainability of these capacities. How do we build in country after each outbreak the capacities across, whether it's diagnostic testing, whether it's the facilities themselves, whether it's the use of emergency operations centers, whether we're talking about infection prevention and control. You know, a lot of people, you know, don't want to talk about COVID anymore, but the legacy of COVID should be, in addition to what, you know, we've all gone through, these capacities that have been expanded in many countries around the world. And that's true for Ebola outbreaks, it's true for Marburg outbreaks and cholera outbreaks. But the challenge with governments right now is sustaining these efforts, finding the financial means to be able to keep the workforce, to keep the facilities up and running in the context of all of the other challenges that they face. And this is not an insignificant problem. So when we go into countries and we're working with countries to support the response for Mpox, it's in the context of everything else that's happening within the DRC, including security concerns. So for us, what we want to see with our member states in support of ministries of health is the building and the leveraging of what's been learned from each outbreak that they've gone through to be sustained as we go forward. And that's something that we have to look at politically, financially, and not only technically.
Thank you so much, Dr. Yao and Dr. Van Kerkhove. Let's try to go back to Dr. Pieperkorn in Gaza. I understand that he may be connected now. Rick?
Yeah, thank you very much, Tarek, and greetings from Gaza. Our internet connection is incredibly unstable at the moment. So now focus on two questions about, what is the current situation, specifically when it's with regard to food availability. The IPC report is going to be out tomorrow, so we will hear more and more data tomorrow. I just want to go back to what we already knew, that almost 500,000 people, what we call facing catastrophic levels of hunger. And if you also realize that 60 to 70% of the livestock was killed or prematurely slaughtered, 70% of the cropland and 33% of the greenhouse area was damaged and actually non-functional. We also, and according to the World Food Program, and specifically the northern governors, and that's already applied for the last couple of months, was very little wheat flour, canned foods, and they were the only items. There were very few dairy products, vegetables, fruits, and eggs. And even myself, what I noticed now here in Deir Bala, call me very regularly. It was 4 weeks ago for the first round of polio, and there was definitely much more fruits, vegetables, and other items available. You don't see them now in the market. I ask, I say, hey, can we buy some fruits, etc. They're not there. So also there, we see this already, the effect. And our partners report, specifically in the north, that there's very little food left to distribute. And moreover, what's important also, the bakeries. So a number of bakeries have shut down, and they are forced to shut down because of the lack of fuel. And Dr. Tedros was referring to, for example, missions and the missions to the north. The WHO, the last mission we had before the mission on last Saturday was the 29th of September. We had 11 attempts of missions to go to the north, not just to evacuate patients from Kamala 1 and Indonesian hospital Al Adwa to Shifa and Al Ahli, but also to bring fuel, to bring the medical supplies to those hospitals and also to Sahaba and other places. And so it said something we were not able to get in, and only after an enormous amount of pressure we managed, after a very complex mission. Today, we got another request from the director of Kamala 1 to assist with medevacing 6 patients from Kamala 1 to Shifa, but also to urgently bring fuel, to bring some certain medical supplies, and to bring in food for patients and staff. So it says all about the situation. And what I got from my World Food colleague, that the only thing what got in of late, I mean, they had, I think since October, what you rightly said, there was no food getting into the north at all. And I think they got 25 trucks in and 15 trucks from UNRWA, but they're still not reaching the population. Yeah, so very concerning, and we will hear more and more details you will hear tomorrow at the launch of the IPC. I want to also maybe add one thing, and it's maybe a little bit of good news. Dr. Tedros raised the first phase of the second rounds began in central Gaza yesterday. the polio vaccination. And I think the first 2 days were good days. I mean, like, there were good days that we reached over almost 160,000 children vaccinated, and 130,000 receiving vitamin A as well, that other target group from 2 to 10 years, polio 0 to 10 years. And that is almost more than 75% of our target for the central zone, which is 180,000. So after that, we will move to the southern Gaza with a target of 293,000, and then to the northern in 190,000. We are concerned about the north because of the repeated, you have seen this, evacuation orders, including for the hospitals and populations around that. And we need to reach all children. We have been successful with polio vaccination against all odds in the first round. We made a good start. We want to finish this job. We need to reach more than 90% of all children. So we expect, and we actually demand, that we have the same area-specific humanitarian policies applicable everywhere. Now, in the central zone, then maybe shifting to the south and to the north. And my last point I want to make, we hear a lot about evacuation of hospitals. So Kamalat 1 is not evacuated. Kamalat 1 is functional, just as Al Adwa is functional. And we need to support that. Those hospitals need to be protected. We're planning now a mission for either Saturday or Sunday to assist with this transfer of patients and to bring the necessary medical supplies and the fuel. Over to you.
Thank you very much, Dr. Pieperkorn. So let's go to next question. We have Yuri Aplev from RIA Novosti. Yuri, unmute yourself, please.
Yes, thank you, Tariq, and thank you for the briefing. My question is about Lebanon and cholera. If I understand well, one case of cholera has been detected in the northern part of the country. I wanted to know what is the risk of a global cholera epidemic in northern Lebanon. And if I remember well, we had an epidemic of cholera during several years in Syria. Is that something that is also threatening Syria at the same time? Thanks.
Thank you very much, Yuri. Let's go to our representative in Lebanon, Dr. Abdenasir Abubakar. Dr. Abdenasir?
Yes, thank you very much. I think, cholera, the first cholera outbreak for 30 years actually has occurred in October 22 until 2023, mostly in the northern part of the country, but also some parts in the central. And I think currently what we are seeing is actually, the first case has been confirmed, but we've been talking about the risk of cholera for many months, actually, because of the deteriorating water and sanitation situations for the refugees, but also the host communities. As you know, Lebanon for the last few years has been impacted by the financial crisis, and most of the public services, whether it's the electricity, the water establishment, and many of these actually have been, the services has been impacted very severely. And because of that, actually, that in a few months back, actually, we visited some of the settlements and also some of the host communities in Bekaa Valley as well as in the north, and we raised the alarm, both WHO as well as UNICEF and the Ministry of Health, that the risk of cholera may exist. And that's why we implemented what we call preemptive cholera vaccination for these high-risk areas. And now what we are seeing is some of the, the communities where we have a confirmed case actually is not one of the areas that has been received the vaccination. And now what we are worrying actually is that displaced people for the current conflict actually have reached to the north. And if the cholera outbreak or the cholera spread to the new displaced people, it might spread very fast because some of those communities from the south and from the Beirut didn't have any cholera immunity for the last 30 years, and the risk of spread is very high. And I think that's WHO is working very closely with the Minister of Health, but as well as the other partners, specifically for WASH cluster partners, to ensure that how we can scale up the water and sanitation in those high-risk areas. But at the same time, also, we activated the cholera preparedness and response together with the Minister of Health and other partners, just to ensure that we take very, proactive response activities so we can contain the outbreak as soon as possible.
Thank you very much, Dr. Abubakar, who speaks to us from Beirut. Let's go to next question. We have Gabrielle Emmanuel from National Public Radio.
Hi, thank you very much for taking my question and for doing this briefing. I had actually two different questions. One, you were talking earlier about hospitals being targeted by Israel in both Gaza and Lebanon. And the counter to that by Israel is that Hamas and Hezbollah terrorists are operating out of the health facilities or operating very nearby. So I wanted you to just address that allegation. The second question I have is about the MPOX situation and the report you did, I think it was number 39, in case that's helpful, but this one focused on North Kivu. And it said that 75% of the cases were in children 0 to 17, but it also at the same time said a third of the cases were sexually transmitted, and I believe a half were among sex workers. So this implied to me that some of the children are getting it through sexual transmission. I just wanted to see if any of you could clarify that finding and what you're seeing on the ground there. Thank you.
Thank you, Gabrielle. So let's maybe the first question when it comes really to definitions, if Steve Solomon, our principal legal officer, would like to speak.
Yes, thanks very much, Tariq. Thanks for the question. So WHO is, as many of you know, monitors and reports on attacks on healthcare. And we do this based on a long-standing mandate established by the 194 WHO member states. WHO does not, however, make judicial determinations. That mandate belongs to other international bodies. That said, WHO does advocate and press for compliance with international law, including international humanitarian law. And in this connection, it's important to convey that humanitarian law itself is very clear. Healthcare workers and healthcare facilities are strictly protected. They must not be attacked, and they must not be used for military purposes. They must be safeguarded at all times, both in military planning and during military action. This core part of humanitarian law has two key objectives. First, to protect healthcare workers and their patients, and second, to protect the health system infrastructure that communities depend on for life-saving care. These critical objectives are why the safeguarding of healthcare is treated so seriously in international law. A failure to protect and respect healthcare devastates twice. First, in the initial harm, and then again for the years it takes to rebuild health systems. The protection of healthcare also includes, as the questioner asked, the prohibition against combatants using health facilities for military purposes. But IHL is also clear that even if healthcare facilities are being used for military purposes, there are stringent conditions which apply to taking action against them. These stringent conditions include a duty to warn and to wait after warning. And even then, disproportionate attacks are absolutely prohibited. In sum, all combatants should understand that health facilities and workers are off limits. Targeting them or militarizing them are both prohibited. Thanks for the question.
Thank you very much, Steve, for reminding us this very important provision of the international humanitarian law. Gabrielle, your second question was on MPOX in DRC, so I turn to Michel first.
Thank you very much for the question. The Clade 1B is a major concern for us because it's triggering quite a rise in numbers. And in North Kivu, we have, as you rightly mentioned, 75% of the cases within the IDPs are children. Tell us also that we should make sure that we have a comprehensive approach while dealing with this response, making sure that water and sanitation for this displaced population is also provided, in addition to also teaching them about the the mode of transmission of this outbreak and also preventive measures that they should take. WHO and partners are working on different means to make sure that we address this specific age group. And I will pass the floor to my colleague, Dr. Anna Maria.
Thank you, Michelle. Just to add 2 points for clarification for those listening to us today. As Michelle says, we have transmission of clade 1A in the endemic areas of the DRC. This is mostly occurring through zoonotic transmissions from animals to humans as spillover events, and then short chains of human-to-human transmission. That is a problem that also has to be addressed and is part of our response plan. But the place where the number of cases is increasing exponentially is related to 1B. And 1B is focused on the Sud Kivu, North Kivu, Kinshasa, and now spreading to Tanganyika, Chopo, and other countries, neighboring countries. In the 1B context, sometimes the virus comes into a community through adults and sexual transmission, but the data suggests that once it's established, it occurs both in children and in infants. And some of the affected areas in Sud Kivu and North Kivu are areas where there are large numbers of internally displaced populations and refugees. As Dr. Tedros announced, WHO has issued a pre-qualification of the MVA-BN vaccine now for children 12 to 17 years of age, which is very important because about 60% of the population of the DRC and the neighboring countries is within this age group. But still, we have a lack of a possibility of vaccinating children below 12 years of age. So WHO is working with Africa CDC, other partners, and with the government of DRC to find a possibility of offering vaccine also to those children. And there is a process ongoing to ensure that through a protocol with data collection and with WHO offering access to our WHO insurance, children can be safely vaccinated. This is important not only because of the children's risk of acquiring the infection, but if they represent 50% of the population at risk, then the vaccination and the integrated approach will already start with a low impact because 50% of those at risk are not targeted. Thank you.
Thank you very much, Steve, and thank you very much also, Dr. Henry Restrepo. Dr. Abdi, would you like to add something?
No, just to clarify the point that specific question asked by the journalist. The data we put forward is aggregated for the whole duration of the time. So the initial clusters that happened was among the 34 cases, but we like to clarify that what we are seeing right now, as Dr. Ana Maria said, once introduction happens inside the household, within the family it can spread. It doesn't mean that there's a sexual transmission going within the children. The initial cluster when investigated was based among the introduction. So in any outbreak, there's introduction, amplification, and spread. So the initial cluster where our data was focused was based on the first cluster. But right now, what we are seeing is a well-established community transmission from mother to children, and it's not specifically to, there's no evidence through the sexual contact among children. So I just wanted to clarify that point. It's a household transmission based on close, intimate family contact within the household.
Thank you very much, Dr. Abdi, for clarifying that point. Let's now go to the next question. We have Health Policy Watch and Kerry Cullinan. Kerry, can you please unmute yourself?
Thank you very much. My question is related to the polio vaccination campaign. I wondered whether Israel had given any indication about whether it would be granting humanitarian pauses in the north. And related to that, I know that there are a number of patients who need to be transferred out for serious conditions that can't be treated there, and whether there's been any progress made to secure their transfers. Thank you.
Thank you, Kerry. Dr. Pieperkorn, would you like to take this?
Yeah, so the second question I didn't get, it's really unstable here. But on the first question on the north, so yeah, we and this I said there's a technical committee, Ministry of Health, WHO, UNICEF, UNRWA, and other partners. So we plan, we manage, we roll out. We have been WHO, UNICEF. We are regularly discussing and negotiating also with the Israeli authorities about this area-specific policies. And of course, our assumption and the current discussions which we haven't finalized the planning for the north, we will, is just the same as for every other zone, so that we get proper area-specific humanitarian policies. And that means for what we have now in the central zone, when we shift to the southern zone, we do the same. And if there's a small area outside that we can reach that. For the north, as I said, we were, of course, we were concerned about all the developments over the last weeks, including the lack of humanitarian support actually reaching the north, including our own missions, as I discussed, food and everything, and evacuation works, and the active fighting going on. So in our discussions, WHO and UNICEF, we are very clear, crystal clear, that we will need an area-specific humanitarian pulse. And that's also our assumption that we will get an area-specific humanitarian pulse for the whole of north of Gaza. And it's really important that we cannot just say Gaza City and then not Jabalia and the rest of the north, because in the north of Gaza, the target is almost 120,000 children. 65,000, let's say, at the greater Gaza City, and around 50,000 north of that. And so you cannot just reach that with missions. You need an area-specific humanitarian pulse, because you will have 60, 70 fixed sites. You have hundreds of mobile teams which need to move around. But most important, the parents need to be able to bring the children in all safety to those mobile teams, to those fixed sites, etc. So yeah, I think we are hopeful, and we also want to stress that the parties who and everyone who made this possible in the first round, and we reached more than 90%. So we don't want to falter. We cannot afford to falter in the second round. We need to stop this transmission of the polio virus. For that, we need 90% coverage. It's very simple. And for that, we need the area-specific humanitarian pulses all over Gaza, including in the north. And we are hopeful and convinced that this is going to work. But I want to make one additional point here. It's great to be I'm now in Darabala, and there is this little bit, this polio bubble. So today I went out, and you see a lot of parents bringing their kids, and it's almost a little bit of a festive mood. It's almost to a certain extent as a sense of normality, that people move around and are happy to be vaccinated. I said it in the first round, we cannot just have this polio bubble. Like beyond polio, there's so many other challenges, urgent needs with health, which we need to address. And we mentioned a number of these missions, fuel, medical supplies, etc. And you would expect, after one war in this crisis, after 1 year in this war, even if there's no ceasefire, that there's agreement, proper agreement about humanitarian policies, humanitarian corridors, however you call it, where the UN, WHO, other UN agencies, humanitarian partners can properly do their work and deliver, not just for health, for food security, for wash, for shelter, etc. And that should be the rule. We, of course, all want a ceasefire. If there's no ceasefire, we should need and we should have this humanitarian corridors and a functional deconfliction mechanism by now. So we are grateful for this area-specific humanitarian policies. And when we can do polio, we can do much more. When we can do this against all odds, we can do much more. We do much more, and we are able to do much more. So give us this area-specific humanitarian policies also for other areas and for the long term, even when there is no ceasefire. Over to you.
Thank you Dr. Pieperkorn. And second question Carrie had was, is there any progress regarding medical evacuations outside Gaza for all those thousands of people who need to receive medical care and who cannot receive it in Gaza? Any progress on those evacuations?
Yeah, a good question. Of course, we have seen that since the Rafah crossing closed, it's now on the 6th of May, 6th or 7th of May, we have seen hardly any medevac. We have seen 282 patients medevaced, and actually with support, with very much managed and supported, facilitated by WHO and PRCS and partners, very much. And I want to also say thank you to the UAE, because most patients actually from there went to the UAE. And more than 1/3 of that were actually children and their companions. What WHO has consistently been requesting for, consistently, we need an organized medevac. We cannot have this ad hoc approaches. We estimate that more than 12,000 critical patients need to be medevaced outside Gaza. And so we need a regular, sustained medevac procedures. We need medical corridors. And the first one to be restored is the traditional referral pathway, which is from Gaza to East Jerusalem and the West Bank. That should be restored. The hospitals in the West Bank and East Jerusalem are ready to receive those patients. Second corridor should go, of course, to Egypt and to Jordan. And from there, if other countries are willing to accept those specific cases needed. And the last point I want to raise that you've seen the study on trauma and trauma care from WHO, which analyzed the data from the EMTs from January till May. And the analysis is quite shocking that 1/4 of the injured Gazans, so 1/4 of 98,000 injured Gazans, 25,000 people, they will need lifelong assistive support, rehabilitation services. And many of them will need also additional specialized surgical operation, of course, and then rehabilitation, physiotherapy, etc. So also a huge part of them need to be medevaced outside of Gaza, including, of course, the chronic cases. Before this crisis, between 50 to 100 patients per day were actually referred to East Jerusalem and the West Bank. And almost 30 to 40% was oncology related. This needs to be restored as urgently as possible. Over to you.
Thank you, Dr. Pieperkorn. Mr. Nabil Tabal, would you like to add something?
Yes, thank you. Just also to comment on the need for medical evacuation within Gaza and more specifically for North Gaza, given the current situation and reduced humanitarian access to north of Gaza. As mentioned before, and this is after several attempts, more than 9 attempts to reach North Gaza. We managed with partners to evacuate 19 critical patients, but of course the need remains high in terms of evacuating patients from North Gaza, where access also to supplies, but also to fuel and to keep the hospitals functioning is also very concerning. Over.
Thank you very much, Nabil. And we have time for one more question. We have Belisa Godinho from Portugal Magazine, W Magazine. Belisa, please unmute yourself.
Hi, I'm Belisa Godinho from Global Broadcast Media, based in Lisbon, Portugal. My question is, how will WHO implement the global agreement on pandemic prevention and preparedness? What are the key points and which countries are involved? Thank you.
Well, as you know, Belisa, the negotiations on pandemic treaty are still ongoing, and we hope that countries will come up with a treaty or other legal instrument to help us be better prepared for next pandemic. But I think it's a little bit too early to speak about that right now, unless someone wants to add something. The question was about pandemic treaty and. Steve could talk. I don't know, maybe Steve is online. Maybe Steve, can you tell us a little bit where we are with the negotiations?
Thanks. And Tarek, it's very helpful that you recalled for our questioner where things stand. Member states, all 194 countries that are part of WHO, are actively negotiating now with the aim of delivering an outcome either in December of this year or next year by the World Health Assembly in May. So that would be May 2025. And that timeline was agreed by the member states at the last Health Assembly this year in May. So they're working with the aim of delivering a pandemic agreement for, as Tarek pointed out, the better global preparedness, prevention, and response to future pandemic threats. And the next meeting, formal meeting, will be next month. But member states are working informally all the time, and with the support of the Secretariat and the Director General, I think there's a lot of encouragement about delivering an agreement that will put the world in a much better position to work against future pandemic threats. Thanks.
Dr. Van Kerkhove, would you like to add something?
Yeah, I do. I want to just use it as an opportunity to emphasize that while the negotiations are taking place, and we're very hopeful that the negotiations will proceed and that we will have a pandemic agreement soon, pandemic preparedness, readiness, response is now. So we are working with all of our member states right now in a variety of different ways to ensure that we are ready for the known threats and we are ready for the unknown, the disease X threats that we face. We do this in multiple ways. We look at this through an emergency landscape of prevention, preparedness, readiness, response. We look at this through the capacities lens according to our HEPA framework of collaborative surveillance, community protection, safe and scalable care, access to countermeasures and coordination. We do this looking through specific threats that we know about, like respiratory viruses or arboviruses, and using a One Health approach. Because most of these pathogens are zoonotic in nature. So if we're looking from a public health perspective at preventing the next outbreak, epidemic, pandemic, we have to look at animals, we have to look in the environments that we share, and looking at how the drivers of spillover are changing with the changes in climate change that the world is facing right now. And we're also looking to support our member states in pandemic preparedness as it relates to governance systems and structures and financing. Again, we have many mechanisms that exist, like the Pandemic Fund, that are supporting member states with surveillance, with workforce, with laboratory diagnostics, which is very helpful to address the sustainable financing. And if I can, bring it also back to the investment round for WHO, why it's so important to fully fund WHO, because we are the secretariat of 194 member states. We work for member states around the world to make sure that the capacities that exist now are strengthened to have earlier detection and verification of these signals that are happening around the world, that urgent actions are taking place so any of these types of events can be mitigated and we don't see further spread, and that we are supporting with clinical care, we are supporting with infection prevention and control, and all of the different aspects of those response. So just wanted to use this as an opportunity to say that pandemic preparedness is happening now, even as these discussions are happening with the member states. But that agreement is so critically important because we have to do better the next time than we did during COVID-19.
Thank you. Indeed, we're all following that process. Let's have that last question. We have our friend John Zagacostas online. John, please.
Yes. Good afternoon, Tariq. My question is to Dr. Tedros. Looking ahead, Dr. Tedros, what's your message to the G20 leaders that will be meeting in Brazil next month? I'm sure you will be attending, but before that, there'll be the G20 health ministers meeting in a few weeks ahead of that. What are the 2 or 3 core issues you want the G20 leaders to focus on? Thank you, sir.
Thank you, John. Dr. Tedros?
I think I would prefer to ask them through other means than through the media. And I hope you will agree with me, John, because I think the first communication should be through other means. But maybe from what we're doing, I can tell you our priorities so you can guess what we may ask. As you know, we have a new GPW now, 4 years. And based on that, we have the investment round, meaning the financing of the GPW. The GPW is a global health agenda, as you know. And it covers the priorities, and it was prepared based on the very extensive consultations with member states and with partners. So I think the support from all member states, especially the G20, to implement the GPW 14 will be crucial, meaning mobilizing the resources. And I indicated it in my speech today that Brazil has already assigned some time during the G20 meeting to discuss about the GPW and the investment round or the funding that's needed to implement. As you know, the GPW is prepared based on SDGs. So that's number one, to be honest. And many of the global health priorities are there, and I think focusing on that will be very, very crucial. And then the other issue is so linked to it is the financing, as I said. And the other issue is on pandemic preparedness and response. On pandemic preparedness and response, as Maria had indicated earlier, we're not waiting for the pandemic agreement only. We have been doing many things based on the lessons learned. As you know, we have established the Berlin Hub or for pandemic intelligence. And this was based on some of the lessons learned, especially the weaknesses in the system with regard to surveillance. And the other is the BioHub, which we have established here in Switzerland. The BioHub is then to address the challenge we have faced again during this COVID pandemic, lessons learned from it, especially in pathogen sharing. So that I think can be addressed through the BioHub. And then, as you know, equity was a problem. And that's why we have established the mRNA transfer hub to boost local production. And that BioHub is established in South Africa, in Cape Town. And I can go on. And if you know, as you know, the pandemic fund also, in order to finance, which was established now in partnership with the World Bank. We have a joint secretariat in the World Bank, and that's also been done. And then there are many other things like the UHPR and so on, which are already in the pipeline. Then, of course, we need the pandemic agreement as well, because it can help us to start things that are not covered within what I have already outlined earlier. Because so we're moving based on the mandate we have, we're already moving forward and based on the lessons learned from COVID, establishing things, but the pandemic agreement is central. So I hope during the G20, I think the pandemic agreement will be will get the necessary support as well. We're aiming to conclude the agreement this year. I mean, the member states are aiming to conclude the agreement this year. And we believe it can be done. They're very close, by the way. And this pandemic agreement is, the negotiation is being done between the 194 member states, between them and for them. And whatever outcome they will have will be implemented based on their respective national laws. And whatever is now flying around in the social media saying this pandemic agreement will cede sovereignty to WHO is actually not true. It's an outright lie. I just want to underline that. And I hope the G20 will say that. They will say the G20 and other member states, they're negotiating among themselves, and the outcome of this document or agreement will be for them, for the member states, and they will implement it based on their own national laws. By the way, 2 years will be given to ratify the pandemic agreement. And they will have 2 years to think about even joining or not. So, it doesn't affect actually the sovereignty. Even joining the agreement will be a voluntary one, because if they want, they will ratify. If they don't want, they will not. So I hope the G20 and others will say this. This is not about the WHO Secretariat. This belongs to the member states. And I think that will be the other important agenda. So the GPW14 and the investment round, the financing of it, and the pandemic agreement. These are the key ones and the timely ones. But of course, there are many other issues that has to be, that should be addressed also by the G20. One is the global, what we see now, the climate change and health. As you know, climate crisis is a health crisis. This meeting will be done almost close to the COP29. And climate change and health, I hope, should be given attention as well. And the other is on AMR, especially with the political declaration, the high-level meeting. I hope the G20 countries will give it their support as well. As you know, the antimicrobial resistance is a silent pandemic, and because of the misuse of antibiotics in humans, in animals, and also in agriculture, we're losing many of the effective antibiotics we have, and the advance in research and development to find new molecules is also slow. As you know, this means has serious repercussions, and I hope they will also give support to the high-level declaration, which was was issued in September, just last month in New York. So these are the issues among the long list among a few of a long list that I can give you, but maybe two important issues are the health delivery we're providing, especially in conflict areas, Ukraine, Sudan, Gaza, now Lebanon. Of course, there are many others because which are dwarfed by those four conflicts. But two things here. One, getting access during conflict is becoming very problematic, and people are dying because of lack of support, especially in conflict areas, lack of access. And then the second part is increasingly we see that health facilities are being attacked. Health workers are being attacked, and many are dying, are getting killed actually. So I hope this should also be taken seriously by the G20 countries, because they have, I think, they have influence. So our ask here is, one, giving more attention and not to forget conflicts like Sudan, which is a serious crisis that displaced already a quarter of its population. And second, in all conflicts, access is key. And third, in all conflicts, protecting health services and health providers is central. But for all this, the last message I have is, it's not aid which is important here, to be honest. It's peace that comes first. We're witnessing now, people we have saved today or we have vaccinated today end up being killed tomorrow. So what's the point? And the level of destruction, especially if you see in Gaza, is just unbelievable. And Gaza has become now, I don't know if it can be inhabitable. It's in more than 70% of its infrastructure is gone. So I don't think aid is now the issue, to be honest. The focus should be in addressing the conflicts politically and focusing on bringing peace. And as we always say, there is no health without peace, and there is no peace without health, and the best medicine is peace. I didn't want to say much to communicate with G20 countries through media, but John, may I just try. So with that, I think we're closing also. So thank you to, dear members of the press. We really appreciate your regular attendance. Thank you for your continued attendance at our press conferences. And we really appreciate your time and interest in our work. We don't thank you much, actually, but you're helping us in really communicating with the public, and we have seen your consistent participation in our conferences, press conferences, and please accept our gratitude and appreciation. And see you next time.